Good morning, good afternoon, good evening, depends on where you are. It's a pleasure to welcome you to a very special webinar today, a webinar that's focusing on TAPS or twin anemia polycythemia sequence, and that's really to celebrate the International TAPS Day, which is tomorrow, the 3rd of March. It will be great to use this opportunity to raise awareness and also to really recognize the people who did huge amount of work on TAPS. And we have, it's really pleasure to have some of these people here on the webinar. Particularly, obviously, Professor Enrico Ropriori and Stephanie Ernest. And I'm going to introduce all the speakers in a second, but I'm really delighted that we have them today with us in this webinar. The webinar is usually recorded. I was so delighted to see that actually we have more than 1,800 people registered for the webinar today. And it's great because people are aware of TAPS and interested to hear about TAPS. So that's really, again, it's just a recognition of the huge amount of efforts of researchers and clinicians and advocates like Stephanie in raising awareness and making the case to look for TAPS and how to monitor, and what's the best management for it. So a huge thanks to all the speakers joining us today on the webinar today on a Sunday, and also a huge thanks to the delegates, all of this more than 1,800 people who registered and people who actually managed to join with us live. And of course, huge thanks to my team, amazing hardworking team behind the scene who made sure that these webinars are organized efficiently and they run smoothly. For the webinar, as I mentioned, they are recorded, they are free, they are available. The recording is on the JOFIC, the charity website, so you can go and access them and listen to them at your convenience. Because they are recorded, we tend to just mention at the beginning that by the fact that they are recording, by the fact that you're joining, you're giving consent to be there, you can switch off your camera, but your name might be there. And we tend to mute all the people joining the webinar so that to avoid any noise, background noise, or any inconvenience to the speakers while they're giving their talks. But please communicate with using the chat function in Zoom. So please put your comments or questions. We'd love to hear from you. My favorite part of the webinar is usually the questions and the discussion. So please, I'd love to hear from you. Just a final but very important point is about the survey. So if you saw the video, there was a QR code, which is an international survey. We want to see what's your practice. Do you monitor? Do you screen for TAPS or you don't? Where, what staging do you use? What postnatal management do you offer to these babies? And we will also put the link in the chat. So apart from the QR code, which will also be available at the end of the webinar, we are also going to put the link to the survey. So please take 5 minutes of your time and just go through the questions. You can do it either during the webinar or at the end of the webinar or even afterwards. So it's really important because that gives us an idea about what's happening in around the world. So I'm gonna, that's my housekeeping that I wanted to share with you. And I'm gonna start by introducing the first speaker. Is a legend in really when it comes to TAPS. It's my real pleasure and honor to have Professor Enrico Ropriori joining us today. He is a professor of neonatology. He's a lead of the academic unit in neonatology in University of Leiden. And it's a fetal therapy center in the Netherlands. And he did, if I think of anyone, I think he's done a huge amount of work on TAPS. So it's my real pleasure to have him as the first speaker on the webinar today. Thank you, Nico.
Thank you, Asma. Thank you very much for the kind words. Let me see if I can share. Am I sharing now the screen? Is it going?
Yes, you are. Right? Yes, going very well.
Okay. So hello, everyone. And I will start with a presentation, and I will, as a neonatologist, tell you mostly important things that pediatricians and neonatologists need to know about the management and outcomes of TAPS, and tell you also a couple of new things. And a lot of the slides that you were going to see in my presentation are not done by me. So I wish to give the credits to the one who made these beautiful slides, which is Lisanne Tollenaar. She is a doctor in gynecology, and she did her PhD on TAPS. And this is the cover of her PhD thesis. And she has an incredible talent of making beautiful slides. So again, all the credits to her. What is important for neonatologists to know about TAPS is that they have a very important role in making and reaching the diagnosis, because half of the cases of TAPS are not detected antenatally. So the diagnosis in these half of the cases is often made only after birth if the neonatologist and the pediatricians think about this disease. Why is it missed? Well, for one reason, and we're going to talk about it today, there is still no screening for TAPS, so that's why we miss it antenatally. And sometimes there is screening, but the screening is false negative, so it's not all a perfect screening. So that's important to realize. So what does this mean? It means that at birth, neonatologists and pediatricians who attend the delivery of these twins are surprised by seeing this kind of things, a red and a white baby, without expecting that, so in half of the cases. In the other half, they knew about it, so it's less of a surprise. But even then, it's always quite shocking to see this, and they have to know what this disease means and what they need to do. And the first thing they need to know is that this is not TTS. And that's a major confusion still, almost now 19 years after the first publication on TAPS. We still, even at our hospital, make a confusion about TTS and TAPS. And I will try to explain the difference between the two so that maybe at the end of this webinar, you will have less confusion. It will be clearer, I hope. Now, the biggest difference between TTS and TAPS is that TTS is a diagnosis that can be made and is always made by the gynecologist. By doing the ultrasound, they see these huge differences in amniotic fluid between the donor and the recipient, oligohydramnion in the donor, polyhydramnion in the recipient. They see the full bladder in the recipient and empty bladder in the donor, and all these others abnormalities which are now quite well known for TTS. In contrast, TAPS, there are not these differences like in TTS. There is no difference in amniotic fluid. There is no oligopolyhydramnion. The only way you could diagnose it antenatally is if you look carefully, and I will talk about it later on, with the Doppler flow at the middle cerebral artery, but this is often not done. If you do that, and more people are aware of this and are looking with the Doppler ultrasound, you will see that in the donor who has fetal anemia, the TAPS donor, if you then measure the middle cerebral artery, the peak systolic velocity, you will see that because of the fetal anemia, it will be increased, high. And this is typical of a TAPS donor. And if you then do the same, but then in the recipient who has polycythemia hyperviscosity, you will see that the velocity in the recipient is lower. And this discordance in velocity is typical of TAPS. If you then plot the values in a graph, you will see the discordance between the two values. And we often explain this to parents by saying that the donor has thin blood, which flows quickly. Just the blood is like lemonade, like water, whereas the recipient has very thick blood, like ketchup, and that's why it flows slowly. That way, parents often understand this better. The other difference between TTS and TAPS, a very important difference, is that a mother who is pregnant of these monochorionic twins and develops TTS will have several alarm symptoms, which are typical of TTTS, a rapid growth of the belly, contraction, sometimes rupture of the membranes because of these contractions, reduced fetal movements, and shortness of breath. But this is not the case in TAPS. In TAPS, there are no symptoms, and that's why screening is so important. Without screening, you will not detect TAPS without using the ultrasound. A third difference between TTS and STAPS is that for TTTS, it's very clear that the best management is fetoscopic laser surgery of the vascular anastomosis, but this is not so clear in TAPS. It is absolutely an option, but there is no trial yet with the showing that this is better than other options. So the optimal management antenatally for TAPS is not as clear as for TTTS. One of the other options antenatally to treat TAPS is given intrauterine blood transfusion to the donor. But it's important to realize that if you do so, you will increase the hemoglobin level in the donor who is anemic, but that blood can then flow like the rest of its blood of the donor towards the recipients and maybe increase the polycythemia hyperviscosity. That's why sometimes if you do this procedure of a blood transfusion, you might envisage combining it with a partial exchange transfusion to avoid increasing too much the hyperviscosity in the recipient. So let's get back to this situation at birth when a neonatologist or pediatrician sees this, a red and a white baby. What is important for the pediatrician to do? Well, the first thing that, and most of the doctors do this, is measure the hemoglobin count. It will be low in one baby and high increase in the red baby, the plethoric baby. This everybody does. What often is omitted and forgotten, and it's very important to do in TAPS, is measure the reticulocyte counts. Because TAPS is a chronic disease, a disease that takes weeks to develop. So the baby that is anemic will have a lot of time to try to compensate the low hemoglobin by increasing the reticulocyte counts, which are young red blood cells. So reticulocyte counts in TAPS donor are high, are increased. And this is, of course, not the case in the recipient twin. They are low or normal because that baby doesn't need to make more hemoglobin. It has already more than enough. So remember to measure the reticulocyte count. And how is the diagnosis then made after birth? Well, there are 3 criteria for the postnatal TAPS diagnosis. One is there must be an hemoglobin difference larger than 8 grams per deciliter. If it's not, if it's lower, even if they have a different color, then it's not officially TAPS. Then if you measure, and if you remember to measure the reticulocyte count, you have to divide the reticulocyte count from the donor by the reticulocyte count of the recipient. And if the ratio is large, as a sign of a discordance in reticulocytes, then if it's above 1.7, this is typical of TAPS. What you need to remember is you need to use the right unit for the reticulocyte count, not the absolute level, but the percentage or promillage, 1 or 2, it's this, as long as you use one of the 2, it's good, but not the absolute level. You have to divide, so the promillage or the percentage. And then the third criterion is look at the placenta, because a placenta in TAPS is very typical. It has only very tiny anastomosis connecting the 2 circulation. If you see large or many connections, then it's not a TAPS placenta. This is a typical TAPS placenta. On the right side, you see the share of the donor, and on the left side of the recipient. And with the naked eye, this is of course after injection with colored dye. With the naked eye, you may also maybe not even see the vascular connection, but then if you look more closely and you look along what we call the vascular equator, you will see in this case, for example, only one tiny anastomosis, smaller than a millimeter. And this anastomosis is, as you can see, from from green, that's an artery. We inject arteries with green or blue and the veins with yellow or red. And so a green to red anastomosis is what we call an arteriovenous anastomosis, so an artery from the donor connecting to a vein of the recipient through the cotyledon, so the color dye doesn't mix, it goes inside a capillary network. And this connection, only this connection was enough to create the TAPS in this case. And in the beginning, 20 years ago, people had difficulty realizing or believing that this could be a real cause of this problem, but now it's more and more accepted. If you then flip around the placenta, you will see this typical color difference, which is very pathognomonic for a TAPS placenta, with the pale part of the donor and the plethoric part of the recipient, which is exactly the same as the color difference in the babies. This is you can see on the right now the recipient who is very plethoric and the donor who is more pale. And again, the same difference is seen if you look with the ultrasound. You see this placenta dichotomy, so difference in color between the placenta of the donor, which is often pale and hydropic, and the other color is for the recipient placenta. This is another TAPS placenta, just to illustrate how typical it is, but this is a placenta of twins that had TTTS in the first place. And because of the TTS, they were managed with laser surgery. And with the dotted line in white, you can see the laser line that was made for the surgery of the vascular connection. And one anastomosis was left patent by accident on the top of the picture. And this is a blue to yellow connection. So this time the donor is on the left side of the picture, and the blue vessel is an artery connecting with a yellow vein from the donor. Did I say the donor on the left side? I mean the recipient. Yes, and connecting with the yellow vein of the recipient. So the baby on the left side was giving blood to the baby on the right side. And this is, again, so an artery to vein connection, very small, as you can see, smaller than a millimeter. And that was enough to create this hemoglobin difference and color difference between these babies. So again, this is a typical picture of TAPS babies at birth. A red and a white baby make a picture at birth, because after a couple of days, after a week or so, maybe because of the transfusion and the corrections, the color difference will have disappeared or will be much less clear. So it's important to remember to make pictures of these babies. However, if you have a red and a white baby at birth, doesn't mean that it's always TAPS. TAPS is a possibility, but there are also other options. And one of the other options is what we call acute peripartum TTS. And the difference between TAPS and acute TTS is that TAPS is a chronic form, and acute, as the name says, it's something that occurs very quickly during delivery. It's more rare than TAPS, but it causes the same differences in color and the same difference in hemoglobin. So how can we make a difference between these two diseases, between TAPS, the chronic, and the acute peripartum TTS? Well, you cannot make the difference by looking at the hemoglobin's discordance only. Both have to be above the 8. But the reticulocyte counts, if you measure that, will only be increased in TAPS, because in acute TTTS, there is no time for the donor to make more reticulocytes, so the ratio will be low, around 1. Then if you look at the placenta, very important, you will see that in the acute TTTS, you must have very large AA or VV anastomosis. AA meaning between two arteries and VV between two veins. Why? Because these are bidirectional anastomosis with a very low resistance, meaning that blood can flow from one baby to the other very quickly. And that is needed to have an acute TTTS. You cannot have an acute TTTS through tiny anastomosis, AV anastomosis. This is impossible. That is only something that can happen in TAPS. So if you inject the placenta, you will see the difference between the type and size of the anastomosis between the two. However, this is often not done in many centers because it's difficult to inject placenta. So what you can also do is flip around the placenta, and if you see a color difference between two sizes, then it's more typical of TAPS. Why is it important for neonatologists to make the difference? Is because the transfusion management at birth is completely different. In acute peripartum TTTS, the donor has hypovolemic shock because it lost blood quickly. That's why you need to transfuse quickly red blood cell or a saline volume bolus to correct the hypovolemia. In TAPS, the donor is normovolemic. It has had a lot of time to compensate to have a normal volume. It is anemic, so you often need to give a transfusion, but you have to do it slowly, not quickly, because otherwise you will make it worse. The recipient, in both cases, they are polycythemic, but it's only in TAPS that you often need a partial exchange transfusion, because that is often very much worse than the polycythemia in the acute TTTS. And then there are other very important things that you need to know if you're managing TAPS at birth. And I have 5 additional problems that occur only in the TAPS donor that are very important to know. One is that these TAPS donors do not only have a low hemoglobin level, but they also have a low albumin level. So the transfusion from one baby to the other is not only a transfusion of red blood cells and hemoglobin, but also of other factors. One of the things that we measured is the albumin, which is lower in the TAPS donor, and sometimes in 1 in 5, it's extremely low, below 20 grams, which is very, very low. And it's important to know this because albumin is an important protein that has a lot of other functions. So you need to be aware of this. Another things that we see in TAPS donors, in 1 in 10 of these donors, is pulmonary hypertension of the neonate. So these babies, TAPS donors, because of the anemia and probably the hypoxia and the acidosis, have a higher risk of pulmonary hypertension, needing nitric oxide as a gas to correct this. So it's important to be aware of this and to be prepared to maybe need this treatment. Another thing that we saw in these TAPS donors is a higher risk of hypoglycemia. And this hypoglycemia in TAPS donors is a hypoglycemia that can persist not only at birth, but also in the first 24 hours. So it's important to be aware of this and also to know that they have also a higher risk of lactate acidosis, twice as much as in the recipient. And then a new finding that we just wrote and discovered recently is that the TAPS donors have a higher risk of iron deficiency. Almost half of them, this is a small study, not yet published, we just submitted the paper, is that almost half of them have low ferritin level. And we think, it's our hypothesis, that because they lose all these red blood cells in a chronic form, they have to compensate by making more red blood cells, making more hemoglobin. And by doing that, they will use all their iron depositions. So they will have less and less iron because they need that iron to make to compensate for the anemia. And because of that, they will be at birth have a lower ferritin and a lower iron, so a higher risk of iron deficiency. And if you put all these things together, you will not be surprised that these poor donor twins have a higher risk, not only of short-term adverse outcome, but also of long-term adverse outcomes. The recipients, their risk is around 3%, but in TAPS donors is 1 in 6 will have a risk of neurodevelopmental impairment. NDI stands for impairment, neurodevelopmental. And why is that? Well, because we find out by chance, by following up these children, is that 1 in 8 of these children, 1 in 6, sorry, has bilateral deafness. And this is a very strange finding. We are still trying to understand what is causing the deafness, but it's very important to know this because this could be very well the cause of the mental developmental delay that these babies have. And why is that? Well, because this deafness is not a typical deafness. It's not going to be detected at birth using the normal hearing test. It's an auditory neuropathy. So it's the nerve that is affected, the nerve that connects the ear to the brain. And because it's affected, you will only detect this neuropathy if you use a special test, which has to be done in all TAPS donors. It's a brainstem evoked response audiometry, auditory brain response also called. And if you do that, you will detect this auditory neuropathy. And it's very important to be aware of this because if you detect the auditory neuropathy in this TAPS donor at birth, you can manage them and treat them correctly and avoid these poor babies to develop a speech and delay in the next years because they will be managed rightly by the ENT doctor. So when we look at the long-term outcome of TAPS children and we compare them to other complicated monochorionic twins, you will see that it's very high in acute perimortem TTTS, that we know. It's also very high, 1 in 5 in TTTS treated with amnioreduction. These babies have a risk of 1 in 5 or 1 in 4 of having impairment. It's nowadays much better, around 1 in 10 or even less in TTTS treated with laser, especially if the laser surgery was successful. And it's more or less the same in TAPS, but it's in TAPS, it's increased in the donors and it's lower in the recipients. And if you remember to do the special BERA test, we will be able in the future to reduce the risk of impairment for these TAPS donors. So for me, one of the last slides is the 3 take-home messages for TAPS is that it's important to measure not only the hemoglobin, but also the reticulocyte count. Be aware in donors that they have multiple other problems, acidosis, hypoglycemia, pulmonary hypertension, low albumin, and more iron deficiency. And the most important thing to remember is that you have to be aware that they have a higher risk of deafness. And if you do the BERA hearing test, you will manage them correctly. I want to finish by thanking all the colleagues because the optimal management for monochorionic twins is working together with the gynecology, the team of the fetal therapy, the ultrasound specialists, specialized nurses, follow-up doctors and psychologists and pathologists, and most important in our team, I think, are the young researchers who make all these beautiful studies that are important to understand more and more about TAPS. And I want to thank them. And I want to thank in particularly Dr. Slaghekke and Van de Sande and Dr. Tollenaar, who are 3 doctors in our team that are very much specialized in TAPS. And Margot van de Sande is now doing her PhD on this disease. I thank you very much for your attention.
Thank you very much, Enrico. That was beautiful talk as usual. And thank you for sharing with us also the latest findings from your research and also highlighting the issue of the risk of deafness and the fact that what modality we need to use to look for it. And I'm sure that will create a lot of discussion at the end. Certainly I've been writing some questions there. So I think we'll keep the questions and discussion to the end of the webinar, and we're going to move on with the next speaker. And it's my honor to introduce Stephanie Ernest. Stephanie is not new to these webinars. She's been an asset really and a very, very valuable speaker and contributor to these webinars. Stephanie is the founder of the TAPS Support Foundation, and not just that, so I know her passion is about TAPS, and she will tell us about her own story, but also she is an advocate for monochorionic twin pregnancies. So really very grateful for all your efforts in helping us, encouraging us, supporting the research, also communicating with twins and moms of twins to support them going through but sometimes challenging journey. So thank you so much, Stephanie. You are the next speaker, so please share your screen.
Fantastic, and I hope you can see right now what my slides. So yeah, basically, I've got to pull up. I wish I could claim that I was good with the technology, but I'm really not. But I'll go through the presentation. I'm going to talk about the role of online communities in twin and multiple research today. Asma already gave you a great lead into who I am, but I just want to add a little bit more context to that. I'm Australian born, but I live in the Netherlands. I have done so for the past 13 years. I call myself a TAPS nerd, and I am the founder of TAPS Support, as Asma mentioned. In my daytime job, I work in content marketing, branding, and social media, mostly specializing with companies that have to do with clinical research, training, and education. And by night, I'm a researcher when I'm not playing with my kids or harassing my poor husband. My hobbies include being the vice chair of the International Council of Multiple Birth Organizations. I'm also a member of the Parent, Patient, and Public Advisory Board for the European Standards of Care for Newborn Health. And I am a patient expert for monochorionic twin research. And really, I do all that fueled by an obscene amount of caffeine. So that's a little bit about myself. I want to share a little bit of my story because I think it's really important to give you a grounding of where I come from. I was diagnosed and having monochorionic twins at 11 weeks back in 2013. And everything went pretty normally until about 24 weeks when we were diagnosed with stage 1 TTTS. Now, this in the Netherlands means you were referred to a tertiary center, being the Leiden University Medical Center. And I was hastily expedited there. I was there within an hour. I live an hour away. And from there, it was confirmed that I did have TTTS, and I also had something happening in the background called TAPS. Didn't know anything about it. We were one of those rare cases where TTTS spontaneously resolved. However, the TAPS certainly didn't. And by around 31 weeks, we went to a routine appointment. My recipient had a shadow on her brain. And so they were delivered within about 2 days of that diagnosis. And you guys see that picture of the TAPS twins and you think, oh, okay, that's a typical representation of TAPS. What I want to tell you is that their names are Emily and Matilda, and those are my daughters, and they are now 11 years old. If you look directly below that picture, that's them. They're beautifully color-coded for you, so you know who they are. And yeah, they're now 11 years old. They'll be 12 in December. And they are very typical 11-year-olds, but they do have challenges associated with both prematurity and TAPS. About 9 months after my girls were born, I was invited to speak at the first TAPS symposium, which was part of Dr. Femke Slawkekker's her PhD defense. And about 5 years ago, I had the crazy idea to start a charity that would do twin research and fund research into monochorionic twins, particularly TAPS. And since then, we've raised around 35,000 euros for various projects across the world, not just in the Netherlands. And I couldn't really do it without the support of the team, who not only backed up my kids and dedicated researched them and also gave them long-term follow-ups, but have also supported my craziness and my enthusiasm through the whole way at the Leiden University Medical Center. So moving forward, I want to talk now about the fact that this is an information overload when you are told you have when you are having twins. You get so many words thrown at you, you become fluent in another language, and it can be quite an isolating experience. And particularly for myself, when I was thrown with a rare disease diagnosis, I had nowhere to turn. And this is kind of like an artist's representation of how it feels. And I joined conventional TTTS groups, but there was not really anything there for TAPS patients. We were all told it was the same outcomes as TTTS, and everything would be fine. And it really wasn't. And so with 7 other parents, we founded the first TAPS group online. And from there, it's grown from 7 people up to 1,200 people. And we have members from all over the world. And it's a really great community. And one of my passions is actually talking about online communities. So this is what I'm going to talk about today. I think the first thing is that we need to talk about the demographic of people who are online. And I bet you didn't expect a sociology lecture, but here we are. We have millennials and how they engage with health information. This is a generation of people who were brought up with the internet. So they expect instant access to information. And if you can't provide it, they will go Google it. They are highly educated. They're the largest living generation, and they really are quite tech savvy. This is why I'm not a millennial. I still can't work out PowerPoint. Why they turn to social media is because they are very easily influenced. They seek that peer validation and lived experience, but they also turn to influencers. And so they're trusting social media recommendations over the health-related decisions. And they're arriving to your appointments. They're pre-informed and they have misleading information and anxiety-inducing. And so this is really why we don't want to tell them that you shouldn't Google things, because they will go and do it. They're like the kids with the cookie jar. They will stick their hand in and do it anyway. But rather, don't dismiss what they bring, because that can erode the trust. Rather, engage with it and build the credibility. And guiding patients towards evidence-based sources will help this. And they're starting their patient journey on social media. So these online communities exist because this is a rare kind of pregnancy. And so they're seeking additional information and support beyond what's offered clinically. And they want to connect with people who have the similar experience. They want to have that emotional support. And many patients are feeling isolated and they don't know anything, because 9 times out of 10, they don't know anyone else with twins, or they don't know anyone else who's had TTS or TAPS. So they're filling this gap that exists. And I think this is a really important thing to actually just think. It's enabling faster knowledge sharing that in a way that traditional healthcare doesn't. So I just want to introduce you to my research partners before I talk about the research that we've done. This is Dr. Rebecca Fishbein and Dr. Lyric Nicholas. We are all monochorionic twin parents. We all had complications. And basically, we connected with a passion to really share patient voices and patient experience and with the medical community, because we have a passion for really making sure that patient voices are heard. And so when we looked in 2021, we actually looked at 2 things and we developed a survey. The first one was like how patients are using social media during their pregnancy and what are their motivations. And then also what role did those social media play in their treatment management and their decision making. I won't go into detail because we all know how a survey works. And so these are the results of that information. And this has been published. It was published late last year in Midwifery. But your average respondent was indeed a millennial. They're a female, aged around 30, very typical for social media as well. College educated, and their motivations were exactly as we expected. Finding other patients with similar experiences, learning about their pregnancy, getting guidance from other people, and the emotional reasons, just like seeking the support and finding out more and learning how to advocate for themselves. And some really interesting points that actually came out of that is that about 68% of those participants used that social media during their MCDA pregnancy, and 15% actually reported that that was a higher use. Half of our participants actually reported that the social media impacted their pregnancy management or treatment. And then we look at the second question, which was what was impacted. Birth plan decisions, advocacy. One of the big things is because if we're talking 2021, of course, 2 of the major guidelines in the world, UK and the US, did not have routine MCA Doppler screening at that stage. So patients were coming to these advocacy groups and asking, how can we get MCA Doppler screening? Things along the lines of just how to communicate with your provider about what you want as well. This is really scary. You all wear this thing and it's called a white coat, and that is a very intimidating thing to a patient. So one of the things to consider is like, are you wearing the white coat in the office when you're talking to patients? But when we look at the number of people who took this back, over half took it back to their provider and discussed it with them. And what was really interesting is 70% of these providers actually considered the information brought forward, which is absolutely commendable, because we should be having these discussions. And of course, risks and benefits were also discussed, because it's not always evidence-based information that you find. And it should never replace the medical advice from a provider. And there can be increased anxiety and emotional stress. And there are people in these groups who are going to be negative and scare and shame people into following the line. But what can also do is bridge the information gap for these people and provide the support and help them advocate for better care, help them make better decisions, and helps them communicate better with their providers. And so we know that these patients are turning to online communities for information, support, and shared experiences, and how it makes a decision, how it helps in decision making. But we want to know that these online communities are actually providing quality evidence-based support and preserving the emotional connection that the families need. And so we need really structured, well-moderated peer support networks. And so together with Footprints Baby Loss, we actually have developed a peer support position paper. And I won't go into too much detail because I do have a link that I can link you directly to it, and you can have it. You can download it for yourself, but it does provide, these groups are providing the emotional support and validation, enhancing the care that they're getting. It's not a replacement for traditional healthcare, but it's certainly a complement to it. And these providers are playing a key role because you can direct families to these certain networks, and well-managed groups with trained volunteers are really going to build credibility for both you as providers, but also they're going to give the proper information to parents. And we're very, very proud to announce that this has actually been accepted for publication in Infant Journal. That will be coming out in the coming months. And we have print copies, which is really fun. So we can share those. But yeah, this is a really important part about communities. But these online communities also build real life friendships. And this is so important to show and to demonstrate, because these are families that have traveled not just across the road to other people, but they've traveled thousands of kilometers to meet up with each other and to share their experiences. And this is what these online communities create, is these online friendships, not just a one-time connection, but really lifelong friendships. And so when we move from peer support to research, these online communities are also valuable for other reasons, and they're helping people navigate the pregnancies, and they're providing support that is outside of clinical hours and things along those lines. But how can you as researchers and healthcare professionals collaborate with communities, and how can patient organizations actually help you improve your research and your clinical practice? And this is where we come through to how they can work together. Online communities are really key partners in the research. They are the first point of contact for newly diagnosed patients, and they provide access to a really diverse and engaged range of participants. Patient organizations are also offering you real world insights. And I am forever texting something to the team at the LONC that I find is a common ground in organizations. And we find in our communities, there is always research points that we find. But insights from these groups can actually help improve not only guidelines, but research priorities. And co-designing research with these patient advocates can help lead to better outcomes, because the trials are more patient-centric, but they can also help promote things like surveys, trials, and critical research, and expand the reach of these trials to relevant participants. And why this is important is because there are some lovely new things happening with guidelines, and that is they are becoming much more patient-centric. It is already in the European Clinical Trials Regulation that member states need to ensure that laypersons, particularly healthcare providers and patient organizations, are involved in the development of trials. But you also have a massive, massive update coming to ICH DCP, which is coming. Actually, the Annex 1 and principles are already in place from January. Annex 2 is coming in July. And these are things that they're going to be looking for. Sponsors going to need to start looking for input from stakeholders, particularly patients, to make sure that the trials are fitting that. There is much more of a patient-centric focus in research these days. And patients are no longer subjects in clinical research, but they are active participants, and they are using social media technology to find out more about what's going on. And this is particularly in rare diseases. So the key takeaways I want to give you is that our online communities are here to stay, and you're not going to get rid of them. But rather, as providers, what you can do is guide patients towards more reliable and more interesting, more relevant communities for them. And it takes trial and error, and it just comes from listening to what comes back from communities and what is said that will create that. And, you know, I will always say that I'm very proud of the fact that my community is evidence-based, and we have the data and the research to back up anything we say. If you dismiss the information that they bring to you, then they're going to erode the trust. You're not going to have that connection with your patient, and they may actually turn away or not listen to what you say. But listen, talk to them about the concerns, and provide the evidence-based alternatives. Patient organizations can complement your care, so they will strengthen the decision-making processes and the communication. They support research. Good online communities will always support research, and they'll connect you with engaged participants. And co-designed research comes to better outcomes. And I really want to just give a shout out to the LOMC team once again, because they have been listening to my voice for 9 years about what we've been working on together, but also to JEFOG, because Asma and I have worked on a few projects together now, and this is the subject of the next thing. We have also printouts of these. Is the next webinar is the patient guide to the ESOAG guidelines. That is another thing, but listening to patient voices and hearing what they say can actually help change your research. This is a thought that I like to leave you with, and that is Googling symptoms only tells you what diseases have the best SEO. The first page of Google is not a reliable resource, and that is coming from someone who works works both in clinical research and within these communities and social media. Google is not a reliable source, but the first page of Google is where people will turn. So please add to your conversation with patient things along the lines of, what have you Googled lately? Because this is an important question to ask. They're going to look at it, and you can't tell them not to look. And by extension, ask them what they've also asked ChatGPT, because that's very interesting, and it's a very, very dangerous slippery slope, ChatGPT. So we won't go too much into that, but just add that question into your presentations and to your talks with patients. And these are organizations that I actually work with quite extensively, and I know that are very, very passionate about continuing research, but also giving those patient voices. I have a handout. I will drop the link into the comments. You're more than welcome to sign up for it. All their contact details are there. We don't gatekeep information here. We share it, and we collaborate and cooperate with people. This is my contact information. My last little promo for today is the TAPS Pocket Guide, which is this little guide. It fits in your name tag. It has all the diagnostic criteria you need. I'm doing a little Wheel of Fortune here. And on the back, it has there is a link in the handout that will tell you how to get a hold of those. And we always put in extra goodies. So please get in touch about that. Lastly, I just want to leave this on the screen for a few minutes. And these are actual comments from actual real people about what online communities have given them. And it is so important to just take this into consideration and just listen to the patient voices, because this is what they do. They give the people control. They are giving people information. They know how to advocate. Having people understand the situation you're in, it is really such a change maker. Going from 11 years ago when I was first diagnosed to now, and seeing the spread in information, but also the power of communities has been really quite impactful. So yeah, if you've got questions or you want to talk about it, I will pop the link into the chat section now, but by all means get in touch. But thank you for letting me talk about one of my passions today.
Thank you very much, Stephanie. Beautiful talk. And thank you so much for all your efforts on behalf of everyone on this webinar. And I'm sure many, many people that are not with us. Thank you for your huge amount of efforts. And, just to really say, like, whenever we discuss a project, your positivity and the fact that you really want to do the best to help people, I think that was brilliant. And just, again, from Dr. Romain Trebal presentation, which is a French, which means it's a very nice presentation, very beautiful presentation. So very nice. Thank you very much. There are already some questions that I've been keeping an eye on the question that they arrive, and I'm sure we'll have the question at the end, as I mentioned in the discussion. So we're going to move on, and the next is my talk, and I'm going actually to talk to you today about the controversies, but also really comparison of the guideline where there is consistency and where there are some differences. And the reason which I think is quite topical, because certainly recently there's been a number of guidelines that have been published that have addressed TAPS, whether they are new guidelines or they actually updated guidelines. And I'm going to share with you and show you where they agree and where they actually differ. So if you actually look to start with the diagnostic criteria of TAPS, and we heard earlier from Enrico about the fact that the postnatal diagnostic criteria, where there is a baby that's anemic, other babies polycythemic with large intertwin hemoglobin difference of more than 8 gram per deciliter, but also is this not enough? You also need to have the reticulocyte count ratio of the donor or the anemic twin more than 1.7, or having this tiny anastomosis in the placenta less than 1 millimeter in diameter. TAPS doesn't produce symptoms. It's not like TTTS when the woman is symptomatic because you have the polyhydramnios. Often women don't have any symptoms. And certainly if you try to translate this postnatal into antenatal, the diagnostic criteria, as we heard earlier from Enrico, is with the donor or the anemic twin by looking at the MCA peak systolic velocity, the 1.5 mom, and the recipient of the MCA peak systolic velocity of less than 1 mom. It's true that for anemia, for fetal anemia, the cutoff of 1.5 mom of the MCA peak systolic velocity to some extent is well established. It's well established also from many other studies, older studies. Interestingly, the 1 mom as a diagnostic criteria of polycythemia, that was to some extent questioned in subsequent studies, and I'm going to show you that. But that was definitely the traditional diagnostic criteria of TAPS. Well, how the performance of this diagnostic criteria for postnatal diagnosis of TAPS? Well, with the cutoff of 1.5 mom and 1 mom, the specificity is 100%, or the positive predictive value is 100%, which means when you have it postnatally and you didn't do intervention, the babies do have TAPS. But the sensitivity is not really that high. In fact, the sensitivity is less than 50%, which means that you miss a large proportion of cases of TAPS. Back in 2019, the Dutch team, again led by Enrico Labriore, they looked at actually how we improved the diagnostic criteria and reported that looking at the delta, the difference in the MCA peak systolic velocity between the two babies, that actually improve your ability to detect TAPS. So the sensitivity from less than 50% to 83%, and specificity is the same, 100%. And they found that the best cutoff was 0.5 mom. So looking at the difference in the MCA peak systolic velocity was a cutoff of 0.5 mom. The same year, the German team led by Kurt Hecker also published interesting data where they actually proposed that even a lower cutoff of this MCA, the difference in the MCA peak systolic velocity, so 0.373, so even lower cutoff. And by doing this, you increase the sensitivity to above 90%, and the specificity is lower a little bit to 96%. So there may be some false positive cases. And at that time, really, there was a bit of confusion. I certainly said, well, I'm not sure which one I'm going to use. Should I use the traditional diagnostic criteria? Should I use the peak systolic velocity, the discordance, or which graph should we use? And at that time, that was a trigger for us to do the Delphi consensus to try to unify the diagnostic criteria, speak the same language. And interestingly, the results were not what we expected. So the fact that there was consensus that the donor 1.5 mom, the anemic, because that's anemia, that's to some extent established, and the recipient twin having a cutoff of 0.8 mom, so even lower than the 1 mom that was proposed earlier, but also to include the discordance of the beta cerebral artery systolic velocity as also diagnostic criteria, but with a cutoff of 1 mom, much higher cutoff than the 0.5 mom that I mentioned earlier, or the 0.37. So that was the Delphi, or the consensus. So what do the guidelines or these societies recommend? And I did, in this slide, I did really look at all the guidelines, about the one I managed to access, and I looked at the diagnostic criteria. And if, for example, you see the SMF guideline, which is published only a few months ago, led by Gina Miller, who's our next speaker. And they actually did recommend the traditional criteria of 1.5 mom and less than 1 mom, but also take into account the discordance of 0.5 mom. And certainly in the guideline, they did also acknowledge the earlier discussion that I mentioned too, the different diagnostic criteria and the consensus or the Delphi. The Royal College of Obstetricians and Gynecologists, that's in the UK, and I'm currently a vice president. They updated the guideline, published literally a couple of weeks ago, and they actually adopted the Delphi criteria. So the 1.5 and 0.8 mom, and also take into account the discordance of cutoff of 1 mom. FIGO, there is work which I was fortunate to lead on, that was published, initial version 2016, was updated earlier this year, January 2025, and acknowledged that there is variation in practice, also acknowledged the Delphi criteria, 1.5 less than 0.8 mom, discordance of 1 mom or more. The FIGO didn't really address, that was published back in 2019, so it's probably due for update, and did not really mention any diagnostic criteria of TAPS. NICE guideline in the UK, published back in 2019, and they included the traditional criteria, 1.5 and less than 1 mom, but as I said, it's 2019, so it's about 4 or 5 years old now. About the Italian Society, they use 1.5 mom and less than 0.8 mom. The Canadian and the German adopted the Delphi criteria. So 1.5 mom, 0.8 mom, and also take into account the discordance and the discordance of 1 mom or more. So you can see there is a degree of variation. So what about the incidence of TAPS? And incidence of TAPS, and that's the reason why I spend a really significant amount of time telling you about different diagnostic criteria, because the truth is that the incidence of TAPS will depend on which diagnostic criteria you use. And this is what we illustrated in this study, where we applied the various diagnostic criteria and we looked at the incidence of TAPS in a cohort of monochorionic twin pregnancies. And what we found is that using the conventional or the traditional cutoffs, so 1.5 and less than 1 mom, the incidence was about 8%. And in fact, that's probably the incidence that you would see in most papers or review articles, because this is the studies, this is the older studies. But if you apply the cutoffs, so the delta of 0.5 mom, you find an incidence of 16%. And in fact, if you use the German cutoff of 0.373, the incidence is higher because you have a lower threshold of 19. So almost 1 in 5 of monochorionic twin pregnancies would be labeled as TAPS. What about the Delphi criteria? And the Delphi criteria, I was surprised, but really my explanation of what the results were is that people wanted to select or identify maybe the more severe cases of TAPS. And maybe because the natural history is, there's a bit of controversy, maybe because people don't know how often should we monitor. Also, people who don't know what's the best management yet, because we don't have high level evidence to say what is the best management of these cases. But if you apply the Delphi, the incidence was 6%, much lower. What about the outcomes? And we heard earlier already from Enrico that the fact that TAPS is associated with increased perinatal mortality. And I just want to really make 2 important points. This is number 1, that's spontaneous versus post-laser TAPS. Most cases of TAPS that we diagnose and manage tend to be post-laser for TTTS. So cases that had TTTS treated by laser, and then that's post-laser TAPS. But some will be spontaneous. And what's interesting and clear from the data, that the perinatal mortality is higher in post-laser compared to spontaneous TAPS. And my explanation is the co-pathology, because you have both the pathology of TTTS and TAPS, and the fact that the anemic twin tend to have higher perinatal mortality than the polycythemic twin. Of course, the risk factors will be more advanced and earlier gestation at diagnosis. The long-term impairment, I'm going to try not to repeat what Enrico mentioned, but again, you see that the post-laser, the anemic twin tend to have higher risk than the polycythemic, and already Enrico mentioned about this risk of bilateral deafness in about 15% of the TAPS donors. At that time, we tried to really get some data on the outcomes so that we can use it in counseling these patients and try to differentiate between spontaneous versus post-laser, and also according to the management options. And we did that in this meta-analysis. I'm not going to go through it because of the time, but certainly reiterated the message that I mentioned to you earlier, that post-laser TAPS tend to have worse outcomes, worse prognosis than spontaneous TAPS because of this co-pathology. What about the gestational age diagnosis of TAPS? And the reason why it's important, because if we're going to start monitoring for TAPS, how early should we start? And this is data from the TAPS registry that was led by Enrico. And the spontaneous TAPS was diagnosed from as early as even 16, even sometimes 15 weeks, and as late as 35 weeks, which means that it's not like only look at it after 24 weeks, for example, or only look at it in the third trimester. You can have spontaneous cases very early. What about the post-laser TAPS? It's 3/4 of cases of post-laser TAPS were actually diagnosed within a month, within 4 weeks after the laser surgery. But still, there were some cases that were diagnosed up to 17 weeks after the laser, and therefore you cannot stop monitoring for TAPS. You have to continue monitoring until the end of the pregnancy. So the monitoring, which is something that's really has been in the past quite controversial, and I'm going to show you the latest data or the latest guidelines. So ISWAG, even the previous guideline, the previous version that was published back in 2016, we were consistent that we would recommend that we monitor for TAPS, even in uncomplicated monochorionic twins. And certainly initially we said as early as 16 weeks, so every 2 weeks until the end of the pregnancy. And then we received some correspondence about that, well, it's difficult to do it from 16 weeks, and this is international guidance and therefore should apply to everybody. And certainly the version, the updated one, is 20 weeks. But certainly most centers and the centers that I work at and most centers that look for TAPS, they often do it from 16 weeks from the earlier scans. What about NICE guideline? I was a member of the guideline update that was published in 2019, and we had a long discussion about whether we should recommend routine monitoring for TAPS in all uncomplicated monochorionic twins. And people at that time, there was really divide, and some people, particularly the methodologists on the guideline committee, they said, well, actually, hold on, because at that time, the diagnostic criteria themselves were not very good. Remember, I told you the sensitivity was not that high, it was less than 50%, with a cutoff of 1 mom for the polycystemic twin. And the fact, again, the natural history was not well defined. We don't know the best management. And therefore, the recommendation was not to monitor for everyone, but to monitor for the high-risk pregnancies. And that was cases like had TTS treated by laser or selective fetus restriction, or you have abnormal Dopplers or unexplained polyhydramnias or cardiomegaly, any deviation from normal. And in this guideline, the recommendation was to start the MCA big story velocity monitoring from as early as 16 weeks and as frequent as weekly, and of course, to get advice from a fetal medicine specialist. I mentioned to you one of the rationales or one of the points why they didn't want to really to recommend routine monitoring is the fact it's natural history. Not all cases of TAPS do progress. And at that time, we looked at our data because I was quite modeled by that. And then that was true. So what we found is that whether it's spontaneous TAPS, you see in this pie chart, or the post-laser TAPS, not all cases of TAPS progress. So at the time of the diagnosis, about a quarter of them, 26%, 27%, needed intervention. They were severe enough to require intervention, but actually about only a quarter of them progressed, 40% actually regressed, and about 10% remained stable. So the natural history is still not all of it for progression. And therefore, when you look at the monitoring for TAPS, and the same list of the guidelines that I mentioned to you earlier, I showed you earlier, and you see that actually the good news that almost all the guidelines now do recommend that we should monitor for TAPS. And in fact, almost, I mean, as I mentioned, FIGO did not really address diagnostic criteria or did not really look at TAPS in details, but the guidelines that did, all of them recommended, almost all of them recommended in all monochorionic twin pregnancies, except the NICE guideline in the UK, that's why I spent some time telling you about the rationale for their recommendation or the decision for the high-risk monochorionic twin pregnancies only. But certainly, as I said, that was published back in 2019. That's about 5 or 6 years ago, so it might be due for update. When do you start monitoring? And you can see it's between 16 and 20 weeks. But as I mentioned to you, the rationale behind that, certainly we would like to, in my centers, we do from 16 weeks. But certainly some people say technically it's difficult, and therefore some of certainly the ISWAG guidelines it's from 20 weeks. But for example, if you look at the RSVG, And I mentioned here also G 20 weeks, similar to the ISWAG guideline. But if you look at actually the chart itself, it does say from 16 weeks. So there is a bit of controversy there. But certainly in my centers where I practice, we do it from 16 weeks at the same time as we monitor for TGTS. The staging, and also there's been some variation in the staging, that the original one, the traditional diagnostic criteria, that was the staging, and stage 1 when you have the 1.5 and less than 1 mom. Stage 2 when you have is more severe form of the TAP, so the cutoff, the anemic 1.7 and the polycythemic 0.8 mom. And certainly, but so far the remaining Dopplers are okay. But once you start having evidence of compromise, particularly for the donor, so abnormal Dopplers or cardiomegaly or abnormal ductus venosus, that's a stage 3. And certainly in almost all centers, that is from stage 3 or higher, that would be an indication for fetal intervention. And stage 4, when you have hydrops, often happens of the anemic or the donor twin. And stage 5, when you have demise of one or both babies. And this is the staging that was recommended in the ISWA guideline, also the Canadian or the German guideline. The Leiden team with Enrico Ropliuri, when they propose this 0.5, the cutoff, the discordance cutoff of 0.5 mom, certainly also have a proposed staging taking into account that. But certainly from stage 3 or higher is the same. It's only the cutoff, the stage 1 and 2. The Americans, the SMF, which is led by Gina, they did adopt both. So they took the 1.5 and 1 mom, which is a traditional diagnostic criteria, and included the 0.5 mom as a discordance, but the rest of the staging is similar to the original staging or traditional diagnostic criteria. And again, just to highlight, the Italian guideline, again, adopted that. So there is some variation where they used the Delphi 1.5 and 0.8, but the stage 2 higher, more severe, so 1.7 compared to 1.5, but the recipient was the same 0.8, and stage 3 or higher is consistent across all the classification of the staging of all the guidelines. Okay, well, we're almost there. So what about the management? Well, we have 5 management options. We don't have high quality evidence to tell us what is the best management option. We have the TAPS trial, it's an ongoing. But certainly the current management, you can offer expectant management, particularly in mild cases like stage 1, or preterm delivery, particularly in late or TAPS at advanced gestation, so 32 weeks or beyond. I think it's reasonable to plan the delivery after a course of steroids and maybe magnesium sulfate for neuroprotection, or laser surgery, similar to what you do for TTTS, where you do fetoscopic laser photocoagulation of the anastomosis. And as we heard earlier, the anastomosis in TAPS seem to be very few anastomosis, tiny anastomosis, or transfusing the anemic twin, but you make it worse for the polycythemic twin, and therefore you do partial exchange for the polycythemic twin, or rarely the option of selective termination. And that's often in the context of maybe advanced, with maybe one baby's hydropic at early gestation, or if there's discordant anomaly like brain abnormality, for example. The best data that we have so far is from the TAPS registry. We had almost 400 cases of TAPS, and these key papers that reported the outcomes of spontaneous versus post-laser and versus a management option. And certainly if you look at the perinatal mortality across the 5 management options, you see they're pretty much number 1, there's high perinatal mortality, but number 2, they're not hugely different. If you see, except for the selective termination, which is lower, but by definition, of course, your denominator is already, you lost 1 baby. Yeah, so that's, you have to take that into account when you look at the data. But certainly the message is that the perinatal mortality and morbidity are high across all the management options. Certainly there was variation in the management, and what we noticed that laser surgery was the most frequent intervention. So if you see here that if you look at the perinatal outcomes and mortality, as I mentioned, similar, but the selective termination is lower. The severe neonatal morbidity, again, they're not hugely different, and again, the selective termination was the lowest. But certainly if you look at the time to delivery, you see that there is some variation. So certainly the laser, for example, is about 10 weeks average from the time of the included in the study to the time of the delivery, compared to transfusions only 4 weeks. So that's a potential difference there, where different intervention or different management options might have different outcomes. And the TAPS trial, which is the ongoing multi-center randomized controlled trial led by the Leiden team, where recruiting stage 2 TAPS, whether spontaneous or post-laser, between 20 and 28 weeks. And these patients are randomized either laser surgery or standard management. And the standard management could be transfusion, it could be expectant management, it depends. The primary outcome of the gestation age of birth, and very importantly, they have included neurodevelopmental outcome at the age of 2. The trial is still ongoing, but we look forward to obviously knowing the results. The final 2 points, and it's a really question rather than a statement, is brain imaging in cases of TAPS. Should we be routinely doing antenatal brain imaging, whether neurosonography or MRI? And certainly most guidelines don't really make an explicit recommendation or a statement about this. And I'm going to show you 2 cases. So this is a case of spontaneous MCDA, referred at 22 weeks plus 6 days because it was selective fetal restriction. Also the pregnancy at the same time there was TAPS. The smaller twin was the polycysemic, sort of velocity less than 1 mol, and the larger twin is the one that was anemic. But when I was scanning the larger baby, this was a brain. And I just want to point you out or highlight this posterior ventricle and the periventricular area of the lateral ventricle. And that was the MRI confirmed periventricular white matter abnormality, acquired brain injury, and the parents decided to have selective cord occlusion of this twin at 24 weeks. Another case, which was spontaneous MCDA at 18 weeks, there was a diagnosis of T2TS, was referred, we did the laser, and then 2 weeks later, there was a post-laser diagnosis of post-laser TAPS. So she had repeat laser and transfusing the anemic twin, and 10 days later, this was a brain. Unilateral ventriculomegaly, there's intraventricular hemorrhage here, and on the right-hand side, this is MRI, confirming the findings that I saw on the ultrasound scan. And again, the parents opt for selective cord occlusion. So that's just 2 examples, and really it's open for question and discussion. Should we be recommending doing brain imaging with a neurosonography or MRI in cases of TAPS? And again, just one other point that I noticed is about the postnatal investigation and management. And the guidelines that I mentioned, none of them really address this. So it might be in the neonatal literature, but certainly in our literature, we don't have, none of these guidelines to say on all of these pregnancies that we should be doing placental injection studies, for example, or doing placental histopathology, or do we actually monitor the babies, all of them get tested for the hemoglobin? Do they all get tested for the reticulocyte count? Do they get all hearing tests? What type of hearing test? All of these things are still areas which we don't really have clear recommendations, and perhaps because the evidence is limited. So my take-home messages is that TAPS, the diagnosis, we need to look at the MCA, big exploded velocity. I mentioned to you all the guidelines now do recommend that we should be monitored for it. Almost all of them in uncomplicated monochromatic twins and obviously the complicated ones. And the outcomes, it is associated with increased risk of perinatal mortality and morbidity. The routine monitoring, whether from 16 or 20 weeks, so there's some variation, but there are still a number of areas where there are uncertainties or controversies, and therefore, of course, we need more research that focus on TAPS. Thank you very much for your attention. Okay, so this is just really sharing with you the latest published guidelines and looking at sort of consistencies and also differences across the guidelines. We're going to move on to the last and the best speaker. We always keep the best to the last, which is the case discussion, which we all enjoy and love. And it's my real pleasure to introduce Gina Miller. Again, Gina is not new to these twin webinars. We heard she's been our guest and our speaker for a number of them. And it's always a pleasure to have you, Gina. Gina is associate professor in the Department of Obstetrics and Gynecology, particularly the fetal therapy centers at Johns Hopkins Institute in the United States. And Gina will, as I mentioned earlier, she has led on the SMF guidance on TTS and TAPS that was published recently, a few months ago, and she's going to share with us some cases. Thank you very much, Gina.
Great. Well, thank you so much for the introduction today, and to follow on everybody's excellent points about some of the issues and quandaries that we deal with in the clinical space. I'll just highlight some of those through the number of cases that I'll present to you, and hopefully we'll have some good discussion afterwards. So I'll just go through some of the management considerations for TAPS. And just to start off with monochorionic twins, we know our classic splitting and chorionicity is well described and well documented and understood. However, I do want to mention that whenever we're evaluating a monochorionic twin pregnancy or multiple pregnancy, that unusual things do happen. So if you're evaluating a multiple pregnancy and something looks really strange, this might be TAPS, or this might look like twin-twin transfusion syndrome. It's important to remember that sometimes weird things really do happen with multiple pregnancy. And so some cases have come in the literature that highlight this. So when you're evaluating monochorionic twins or dichorionic twins, if something looks like one of these classic complications that are only seen or supposed to be seen in monochorionic twins, it's worthy to pay attention to them. And just to highlight, as Dr. Khalil showed us, all of the challenges of screening and management, we recognize, particularly when we were doing the SMFM guidelines in this update, that it is difficult to create a national guideline for something when we still have some unanswered questions about the screening and our ability to have a good diagnostic test, that fewer of these patients actually have true diagnostic testing to verify the condition. But we kept coming back to, unless we diagnose and unless we observe this condition, that really is a barrier for us to figure out how to improve our outcomes. And so without identification, the optimal treatment and management will remain unresolved. So I am so grateful for the SMFM for supporting the recommendation to screen for TAPS. And this is to address one of the questions coming in the chat, is how frequent TAPS is identified, or how often it overlaps with other conditions. We know that there's certainly a lot of overlap between all of the complications that are specific to monochorionic twins, and those that have isolated TAPS are really our highest risk for remaining undetected. So unless you're looking for it, these cases might slip by you, and with significant consequence, particularly for our donors. And as we heard, there are a number of management options, and depending on how the case presents, when it presents, that might guide an individual pathway for the management. And so I think somewhat that this is related to why we don't have a clear management strategy that should work for TAPS, since it presents across gestation in the second and third trimester. Technically, each procedure may be more favorable. And so currently, there isn't a clear choice about what is the optimal management. And so we're really excited for the RCT as well. And so I'm just going to highlight a few of these cases to show you how different TAPS cases can present. So this is case number 1. She's 28 years old, first continuing pregnancy at 18 weeks and 3 days, and she was referred for a diagnosis of TAPS. And what's very pleasant is that there was a nice posterior placenta. You can see that in twin A, who is always labeled our recipient, twin B is always labeled our donor. There's clear difference in the appearance of the placenta, as we highlighted the importance of placental dichotomy. We also had the starry sky liver apparent in our twin A. The fluid, because this is not TTTS, right? So the fluid was exactly concordant between the twins, and there was significant elevation in the middle cerebral artery peak systolic velocity for our donor. And so for this, this gave us the diagnosis of stage 2 TAPS, and based on the appearance of the placenta, the location of where we see that dichotomy, it what's lovely is it tells you exactly where you can anticipate that equator to be, and so you know which side of the membrane to enter on. And so in this case, the most sensible choice was laser. Early gestation, clear ability to see the entire vascular equator, good access, and the opportunity to treat this in a single procedure. And so what happened was that we went forward with the laser surgery, and then we were able to observe the improvement of the middle cerebral artery peak systolic velocity, and that you see those coming together and becoming concordant. And so, because especially when you're really interested in following them, we're checking that MCA all the time. And so, so this is a lovely example of treating this in a single procedure with laser. And just to highlight how those secondary signs up here, there is on that placenta, you see the difference, the clear delineation of the plethoric and the hypoperfused section of the placenta, and also those small anastomoses that can be present. And what we anticipate is about 80% of them have one of these additional findings, but I don't think you should, my personal opinion, I don't think you should rely on that to then be a trigger to look for TAPS, because you still will miss a proportion of those cases that may not have it. And so this is how this appears. Overall on the ultrasound, very clear delineation and separation of those placental territories and that hypoechoic starry sky liver. And on the live scan, you just see, as you scan through, you see that clear difference. And also on our post-laser cases, this most oftenly is that single anastomoses that you don't see or you don't appreciate in your first laser. In our series, at least, this is related most commonly to when we have an entry at the transplacental edge, where behind the entry is a sneaky vessel, as you see here. And you can see up in the top left our prior entry from the first fetoscopy. And so that's one thing that's always on our mind when we're following laser cases with a transplacental entry, that we need to monitor for this. So moving on to case 2, this case exemplifies a slightly different appearance for this placenta. So this is a 19-year-old prima gravida. She first presented to us at 21 weeks and 3 days, and she was referred for concern for TAPS as well as selective fetal growth restriction. And so on the imaging, one of the things that's really classic, and for those of you who look after monochorionic twins, we like to call this the everywhere placenta. So with a TAPS placenta, I mean, it is anterior, posterior, lateral, all over the place. And in this example also, the cord insertions were both marginal there at the contralateral edges of the placenta, and with that anterior placenta, there was really poor access for laser, and where we expected the vascular equator to be traversing, there didn't appear to be any way to avoid a septostomy in order to perform a complete laser. And so this was one of the most important factors for how we were considering managing this case. And so on the remainder of the findings on the ultrasound, there was significant discordance of the MCA peak systolic velocity, 0.81 and 2.1 MOM. There was significant discordance between the twins, and so our working diagnosis was TAPS stage 2 and selective fetal growth restriction type 1. And so in the interim, we decided to expectantly manage this case and perform short interval follow-up to help determine what was the next best step. And so over time, we also started observing significant fluid discordance, so a difference in the maximum vertical pocket of one twin. So we developed isolated polyhydramnios and near oligohydramnios for the co-twin. And so we were really hoping that if this patient would just develop TTTS, that we would have the opportunity also to treat with laser. However, that did not happen, and that fluid discordance overall resolved over time and became more concordant. And also, interestingly, the discordance in the MCA peak systolic velocity also resolved over time. And so both conditions resolved with expectant management. Now, ultimately, this patient developed early onset preeclampsia. She did have deterioration of selective fetal growth restriction. And so ultimately, that was the trigger for delivery and closer to around 31 weeks or so. And so at the time of birth, there was significant birth weight discordance of about 50% exactly. The hemoglobins were concordant, and the reticulocyte count was concordant for both of these, for both twins as well. And so this just highlights the circuitous pathway that complicated monochorionic twins can follow, and expectant management was the choice for this one. So another approach here is for case 3. This is a 41-year-old patient, para 2, presented initially at 22 weeks and 6 days for evaluation for TAPS. She also had normal concordant growth, bladders, amniotic fluids, no concerns for FGR or TTTS. There was significant difference in the MCA peak systolic velocities, and again, a classic case of the everywhere placenta with significant discordant placental echogenicity. Once again, there was poor access for laser and an anticipated septostomy if that was the choice that was made. So we started off with a diagnosis of TAP stage 2, and we brought her back in a short interval follow-up and noted that discordance was accelerating. So significant decrease or significant change in the discordance. And so at that point, we felt that intervention was indicated. And so we started off with fetal blood sampling for our donor. And what was interesting is that the opening hemoglobin is 3.1 grams per deciliter. No signs of high drops. So one of the extremely important things to remember in monitoring these cases is you cannot wait for high drops as an indicator for severe fetal anemia. Because of its chronicity, severe anemia can be present without high drops. And so we proceeded with this case with transfusion paired with partial exchange transfusion. And this patient underwent a total of 8 procedures during the course of her pregnancy, performed with serial transfusions. And after the first diagnostic fetal blood sampling on the first procedure, subsequently partial exchange was performed with a variety of volumes there that increased progressively over time. And interestingly, also the MCA peak systolic velocity often did peak every time that we were preparing for the next transfusion. So that's a little bit different also in the few cases that we have in our cohort of one thing you might notice, but not always prior to the subsequent transfusion. That might be different when we're monitoring anemia for Rh disease. And so for this patient, she ultimately was delivered also for early onset preeclampsia and at around 33 weeks. And so there aren't a lot of cases reported in the literature for the use of intrauterine transfusion with or without partial exchange transfusion. And so we recently put our cases together in a series to explain how we perform these procedures, and included 5 in our case series over about the last 10 years, from July 2012 to September 2023. And out of all of the cases of TAPS at this time period, 5 were treated with this strategy. So still a small proportion, or about 6.4% of patients. And within these cases, they generally were treated late 2nd or early 3rd trimester. About 40% had an anterior placenta. Our donor opening hemoglobin median was 7.9, but this is the interquartile range that is represented. So there were a few that were even lower than that. On average, the median transfused was near 50 milliliters per procedure, and that did increase over time. So obviously the earlier ones had a lower volume of transfusion compared to later in gestation. For our recipients, they were significantly polycythemic as expected, and the volume exchange, the median was between 20 and 50 at each procedure, with a significantly lower change in the in the recipient hemoglobin level. On average, these were done about every week, plus or minus a few days, and the gestational age at delivery was median was 33 weeks. So very similar of what we expect after treatment with laser or laser from TTTS. And this is just an example here on the right of our setup, because putting blood, exchanging with saline can be cumbersome. And so to minimize the movement of the needle and the hub, this is an example of the setup that we use to allow blood sampling, testing periodically during the procedure to gauge how far we want to go with our exchange transfusion. And so finally, I'll leave you with one last case of dichorionic triamniotic triplets at 29 weeks. So this patient arrived with concern also for, oh, I am sorry. These are out of order, but this first case started off at first continuing pregnancy, 26 weeks and 5 days, dichorionic triamniotic triplets, who was referred for TAPS. When she arrived to us at this time of gestation, there was significant difference in the middle cerebral artery peak systolic velocity of the two twins. That remained relatively similar. She underwent fetal blood sampling for diagnostic testing, and the working diagnosis was TAPS with coexisting SFGR. And so over time, though, what happened is our donor progressed from type 1 with forward flow in the umbilical artery Doppler to fixed reversed. There was also, again, recurrence of the significant discordance in the MCA peak systolic velocity. So we were challenged with, okay, is this progressive SFGR? Is this TAPS or both? And so at this time in gestation, the plan was for delivery. And so ultimately, these twins were quite different in size. Hemoglobin was similar between them. And so this may have been a reflection of worsening selective fetal growth restriction, but unfortunately only something we knew after delivery. So in summary and in close, this is what our management approach and algorithm is to help guide us for how we monitor these pregnancies when we consider laser versus exchange transfusion or later in pregnancy for delivery. And so this will be available in the slides for those who are interested in having that. And so my closing take-home message is that overall, if we have surrogate signs of anemia or discordant placental echogenicity, then we're more assured of the diagnosis of TAPS. Most importantly, hydrops is not a prerequisite for severe fetal anemia. Also, the heterogeneity of these case presentations is really what leads to the individualized management. And so thank you very much for your attention, and I'm happy to discuss any questions.
Fantastic. Thank you very much. Really enjoyable. I said, we love the cases and actually also having take-home messages from cases, and the diverse presentation and showing how stuff the management can be sometimes be challenging. So thank you very much, Gina. Beautiful talk as usual. And I've been sort of keeping an eye. There are a number of questions that are coming up, and I said like already there's a number of notes and questions I made as well during the various talks. And if we maybe start with the last one, because I think that's one of the questions that were done earlier about the partial exchange transfusion. And do you do it routinely for the first time? So if you have a TAPS case, I think also on the question on what basis we do the laser versus deciding to do transfusion. There's a sort of gestational age, we take into account the placenta location. And do you always do a partial exchange the first time we do the transfusion, or do you wait until you sample and then decide? And how do you make the calculation for so many questions? So, but you get what I'm wanting to.
So, well, and that was the purpose of kind of putting that case series together, because it's been a bit of an evolution, and for each case you kind of figure out for that case what makes the most sense. And one thing that I think has been really interesting clinically is that many times you decide what to do next with every piece of information you get. And so we generally start with the fetal blood sampling for the anemic twin. And so when you open and you have a hemoglobin of 3, you know you're going to be giving a significant volume of transfusion to correct that and to bring that up to a reasonable hemoglobin. And then in the back of your mind, you're thinking, okay, now I'm really curious what the hemoglobin is for the polycythemic twin. And so as long as it's technically feasible, the patient is tolerating well, our goal is to then sample the co-twin next, and we're prepared for an exchange transfusion. So when you open for the co-twin, and you have a hemoglobin of 21 or 22, then that confirms that it makes sense to do an exchange transfusion for that one. We might use a smaller volume. We might use smaller aliquots to start. One of the things I didn't share within the slides is we used the volumes calculations that are available to estimate how much you need for an exchange transfusion compared to what we actually observed clinically. And so there was a pretty significant variation in what we observed versus what would have been the calculated volume you might have wanted to exchange. And so it's not a perfect science that way. And so we sample along the way after the first, second aliquot to figure out, okay, well, what volume are we going to use? So it really becomes often a clinical judgment during the procedure, but recognizing that the first aliquot that you get of that highly concentrated blood and then dilute it, you're going to get the biggest bang for your buck out of the first one, but need to do it more slowly.
Okay, so what's the cutoff for the hemoglobin that you would actually use to do exchange? So above 20, above 19, above 18?
Yeah, usually around 19 or higher than 19. So if we sample and we have 18, then we probably would just leave that be for the first procedure, because the time and it technically is difficult and it takes time. And so balancing the risk of a longer procedure versus the benefit, if you're somewhere around 18, we would probably wait on that one.
Yeah. If I continue just maybe again with the same theme, and I'll sort of share with you our practice is that if we can do laser, we'll do the laser, because I think it's, at least in my brain, that's a definitive treatment. You photocoagulated the anastomosis, and therefore hopefully fix the problem. And it's often actually it's the only one that you need to do, and it fixed the problem. While the transfusion, you know that you're going to start and having to repeat that on several occasions. So it depends on the gestational age as well. That's just our practice. I think that's my impression. That's probably common practice as well. So back again to the transfusion, the exchange. So you said like you had this beautiful image of how you do it. So you're gonna dilute the blood with saline, correct? So
Correct.
You take how many mLs blood you take, and how much you dilute with the same volume?
Same volume. And we have the same approach too. If we think we can do a laser, I would prefer to do a laser and treat it in a single procedure rather than setting up for multiple procedures over time. The thing that often guides us towards exchange transfusion are the later gestational age ones. And also if we're really concerned that we would have to do a septostomy for the laser. So those are kind of the two main factors. But yes, we use the same volume. So somewhere between 5 and 20 cc's of red cells off to dilute with the same amount of saline.
And is there any volume or target, and does it differ with gestational age?
The earlier gestational age, we have a tendency to do a little bit less, of course, because our anticipated fetal placental volume being less. And then and also it depends a little bit on where we open. If we have a much higher hemoglobin, then we might take more off on that first aliquot, because what we also observe is the change in hemoglobin. You might get, a drop 2 points or so. That's really 2 to 3 is really all you're going to get in that testing. So even if you exchange a significant volume, your bedside testing is doesn't reflect that the same. It just doesn't decrease as much. And we observe that there is some cross even in that time period from the fetal hemoglobin stain and the KB from these samples.
Yeah. And again, I mean, for the anemic twin, I think it's much more straightforward compared to the polycystic twin. But for the anemic twin, would you apply the same rules as for just the anemia of other causes or in singleton? So in terms of and when you calculate the volume that you're going to give somebody, and you also aim for a target of 14, for example, and you also take into account that the fact you don't want to give large volume early in gestation, but also the fact that you know that it's likely that you're going to come back and actually give more transfusion maybe in a couple of weeks or so.
Right. I mean, we still target that closing value of 14, and usually on the subsequent one, it's a little, the baby's not as low. You're not starting off as low. So that first one we still are cautious about. We don't routinely give intraperitoneal transfusion to go with it to prolong that time period. That does confound our follow-up as well of trying to assess the stability of that anemic twin. But that's another strategy that can be considered, especially if the access is really difficult or unstable.
Yeah. And I guess you reach also to a gestation, probably 32 weeks the latest, and then you would actually say, okay, well, that's it, and you decide to deliver after steroids and magnesium sulfate. And just maybe on this point, and I can see lots of some questions coming up, Dr. Fauzi, do you recommend any apps for the calculation of the MOMS? So, for example, we do have obviously apps and some algorithms online, and some of them are embedded into the ultrasound database to help you to calculate the MOM, how much blood you would give to the anemic twin. Do you use anything special? I mean, I'm not aware of anything that's specific to TAPS. I don't know whether there is a real need to do something different, what we usually use for the transfusion. I think we use the same. We didn't use the same. I think what probably, I don't know whether this is actually, and I'm not sure anybody looked at it. So for example, we know that in anemia singleton, other causes, we know that the MCA base velocity is maybe the diagnostic accuracy for fetal anemia is less after 2 transfusions, for example. Is it the same for TAPS? How do we decide about when we're going to go back again? So with fetal anemia due to rhesus, there is a sort of, we know roughly how every 2 weeks later, and then maybe every 3 weeks, unless the MCA base velocity is different, for example. Do you use something different, or do you use the same?
No, we use the same. And what is interesting is not a ton of cases, right? But it seems that, you anticipate based on the interval, what the drop is, they behave pretty similarly. Once you kind of get an idea of what that trend is and how quickly they drop. But many times you'll see that the MCA peak, just the day you're planning to do your transfusion anyway, that one is spiked high again. And so that is one just anecdotal observation I have from our cases. So it does seem to be a little bit different than when we were watching our classic RH cases. So I'm sure there are many factors that contribute to that, but it's not every time, and especially after many procedures. But we use in our software package for the calculation.
Okay, fantastic. I mean, this is particular, and the reason why I'm sort of having this long discussion, because this is an area where I think I get a lot of people who ask me, I'm going to do transfusion, I have a TAPS case, how should I do the exchange? Because there's not really clear guidance for it. But we're going to bring it back, come back to it, because I think there's still some remaining question. But I'm just going to move on and bring maybe Enrico and Stephanie to the discussion. So Enrico, the 0.5 MOM that was proposed, and the fact that if you use a 0.5 MOM, and of course the incidence would be more, do you think that if we're gonna start using it, do you think that the most of the literature that we have relies on 1.5 and less than 1 MOM? If we are starting using 0.5, what do you think the implications would be?
So
we're going to see more cases.
Yeah, I understand the confusion because of all these different cutoffs, etc. I think you said it rightly. It doesn't depending on the cutoff, you will have different incidents. But this is a cutoff for the diagnosis, not for the treatment. For the treatment, you need to treat only the severe cases. And not because it's above 0.5, because that if it's only 0.5, maybe most of the cases would not need any treatment. So that is just to reaching the diagnosis. And then depending on each individual cases, as Jenna already said, you will every time make a different decision depending on the case. So it's just a diagnostic tool that you can use in addition to the other things like the starry sky liver, the cardiomegaly, etc., to decide whether or not and when to treat. That's another thing, I guess.
Yeah, and in terms of the postnatal, and I did mention the fact that there's no really standard postnatal management of these cases,
Yeah.
and obviously the reticulocyte count, which is essential for the postnatal diagnosis, I'm not sure there's certainly not all centers would do routine measurements for the babies. What do you, if you would say in an ideal world and you want to say, look, all these pregnancies should have this. So what tests would you do? At what time point do you, like postnatally, would you do it? The hearing test, is it done like, the normal hearing test, at least in the UK, usually done like within, I don't know, a few days, a day or two from the baby's born, but that's just a normal hearing test. Do you think they should all have the special one? At what stage? Is it the same few days? Is it a week, 2 weeks? And then one final question I'm going to squeeze in as well, is obviously all of the natural history and diagnostic criteria for pregnancies that did not have intervention. But once you have intervention, obviously you correct things. So do you still, if a TAPS case that were treated by a laser, do we still need to do all the tests? Do we need to still test for the hemoglobin and the reticulocyte count? If they had laser and then the rest of the pregnancy was fine and remained sort of uncomplicated, it corrected the TAPS.
Yeah, so you're totally true that we don't have any guidelines yet, international or consensus for the postnatal management, the same as the prenatal, I guess. But for the postnatal, what I would certainly advise is to do the reticulocyte count always, and that you have to do directly at birth. Once you start giving transfusions after birth, then the reticulocyte count will drop. So you have to do it before you give any transfusion to know what it is. And that is for reaching a diagnosis. And once you have the hemoglobin and the reticulocyte count, that is the most important. The placenta injection, unfortunately, it's something that only people who have time and patience and the technique can do that. And most of the people will not be able to do that. That's a special technique that you need to learn first, and it takes a lot of time. So the reticulocyte count and the hemoglobin are the most important. And then, as you said rightly, the hearing test, the BIRA test, can be done anytime after birth. You can do it after a couple of days, after a week, after a couple of weeks, but it's important to do the right one and not the autoacoustic emission.
Okay, and just one final question. The reticulocyte count, I mean, okay, I work in the UK and now economically we're not doing well after Brexit. Do we need to test for both babies or can we just test only for the anemic twin? Do we need to test the polycystic twin?
Yes, because if you want to make the ratio means the reticulocyte count from the recipient divided by the reticulocyte count of the recipient. Sorry, the reticulocyte count of the donor divided by that one of the recipient. So you need the two of them. You cannot make a ratio with only one.
Okay, perfect. Thank you so much. We're going to move on to Stephanie. So Stephanie, I loved your talk. I loved your presentation. I love your passion. If you want to give us you've got this opportunity where you have about, 400 or more than 400 that people are actually, but people who would listen to the webinars. What do you think from listening to people? What do you think the message that if you have the opportunity to be in front of all healthcare professionals and say, look, guys, there is this problem, you need to do better. I think there seems to be recurring themes where maybe that this issue is not being highlighted or not being managed properly. What would you tell us?
I have two, and I'm going to take advantage of this situation. The first one is, of course, is that not all online communities are mummy groups who are going to tell patients not to listen to their doctors. We're not all like that. We will work with you. A good group will listen to you, they will engage you, they will take you in, embrace you, and use your knowledge to help better their community. And in return, we will share knowledge with you. It's not rocket science. We will, good communities will always support research and come and talk with you and give good information. And I have always said that if I ever give bad information, I want to know, because I would love to hear back. And the second thing is that I can always back up everything I say with a paper, research, or a professional. And that's the first thing. The second thing is that I really want professionals to take away. There is language around TAPS that is really, really outdated, and that is everything. There is always this myth that TAPS is a form of TTTS. I really want to make it clear it isn't. It is a separate disease. There is an author code for it. It has its own umbrella. In the stand of monochronic compilations, it has its own stand on this umbrella. It is not a form of TTTS. It has separate diagnostic criteria, long-term outcomes. Everything is there to make it a different disease. When you call it a form of TTTS, you are absolutely diluting the urgency of updating screening protocols, of getting information to patients. And not only that, the knock-on effect to patients is there, because these patients have TTTS recorded on their documentation, and this causes problems with things like getting the right hearing testing, getting long-term follow-ups. And I can say this with absolute passion and authority because it happened to me. My children have on their paper from our local hospital TTTS recorded. So when I went to get BERA hearing testing done in 2019, after the long-term effects paper was released, I was denied because it's not associated with TAPS. And my kids' pictures are in the papers, the research paper, we know who they are. And I was still denied that testing. And this is not something that's just happened to me. This is something that I hear in my community all the time. TTS is recorded on our paperwork, not TAPS. So they're saying, I don't need these tests. Please make sure you record the right diagnosis on papers. And please, please, please stop calling TAPS a form of TTTS, because that is absolutely wrong. I'll get off my soapbox.
I think well, this is really clear messages, and I
Yeah.
think I agree with you. I think it's time that we actually differentiate between the two conditions, and I think that's the whole purpose of actually having International TAPS Day and this webinar. So thank you very much for this very clear messages to us. And I've just been sort of through the question. I think most of the question, I would say that they have been addressed during the presentation. I think couple of questions that maybe back to you, Enrico, is about the post-laser TAPS, because I think you beautifully demonstrated, the pathogenesis of TTTS, and the fact that this tiny anastomosis, it's a chronic condition with a transfusion of the red blood cells from the anemic or the donor twin to the polycythemic or the recipient twin. One thing that we struggle with, and I think that's one of the question, I think two of the delegates asked sort of question related to this area, is about the post-laser TAPS, because how would you explain this mechanism of this tiny anastomosis, the chronic condition, with a post-laser TAPS? And in fact, sometimes post-laser TAPS, it happens like 1 week after the laser. So it's not unusual that you would have some degree of TAPS changes, maybe 1 week, as long as mild, we don't do anything, we just wait and often recover by itself. But certainly I've seen a number of cases where laser a week later, actually sometimes one of them is a bit hydropic with signs of TAPS, no amniotic fluid discordance, and it is TAPS, because when you repeat the laser, you repeat the laser, they get better. How do you explain that?
Yeah, so that's good question. The spontaneous TAP, it's clear. It's only tiny anastomosis, maybe a couple of them, sometimes only one, sometimes 3, 4, 5, but not much more than that. In the post-laser TAPS, it depends on how many anastomoses were missed. If it's only 1 or 2, that's usually the case, and they are very tiny. That can cause the TAPS to occur after the TTTS. And the important thing to realize here is that and it's usually the case, if it's the recipient that becomes the new donor, it takes some time for the recipient to become anemic. So if the patent anastomoses are left open, it's an artery to vein from the former recipient to the new, and that former recipient becomes a new donor. It takes a while for that baby to become anemic. And we also know in both situations, in post-laser and in spontaneous TAP, that spontaneous resolution can occur, like you showed. If there is a thrombosis occurring in that IV anastomosis, that TAPS can resolve by itself. That's always a good thing to look forward to, but you don't know if it goes like this or not. So it's good to take good care and follow up these pregnancies.
Perfect. That's great. Thank you so much. And then just maybe final question. It's 1 o'clock London time. So we've been 2 hours on this webinar. So we're going to definitely finish at 1 o'clock. But just a very question from Cheryl from the United States about the incidence of TAPS in monochorionic triamniotic triplet pregnancy. And the incidence is about 5%. This is a paper that we published a couple of years ago. It was a multi-center study, I think about 20 centers got together. Monochorionic triplet is a very rare condition. We put the cases together, including cases from Johns Hopkins and also from Leiden, where and again, the numbers are small, but in this paper, the incidence of TAPS was about 5% in this pregnancy. So that's just answer to Cheryl's question. Okay, lovely. Well, thank you very much. I think we had certainly 2 hours of enjoyment. I really enjoyed the talks were brilliant, the questions were brilliant, the discussion was great. And so thank you very much. Just to remind you again, please spare 10 minutes to answer this survey. Would love to hear from you. It's really important. And also we have a feedback. So there will be a QR code at the end where you have the feedback on the webinar. Tell us what you like, what you didn't like, any suggestions for future for topics for which future webinars. And as I mentioned earlier, I think some of you were asking about the recording of this webinar. It is available. It's free. It's on the Shafik Health Foundation website. And just to really thank the speakers for amazing webinar, sharing your experience on Sunday in your own time and not being paid. So thank you very much for that. I really appreciate it. And also thank you for my amazing team that worked really hard to make this webinar successful. So thank you very much. Tomorrow is the International TAPS Day. So let's get together and celebrate it and make sure that we all know about TAPS. Thank you very much.
Thank you.
Bye-bye.
Bye-bye. For the speakers, please stay.
Can you say something else, sorry?
If you need to go, that's fine, but I thought that it might be nice to give some attention to Tiffany for her for the stuff for editing for the social media. You need to go, it's fine.
I can't hear you because of the music, sorry.
Okay, so the reason and just a suggestion, because I think it would be good to give Stephanie some material when she's working on the editing and having sort of for stuff for social media. I texted Enrico. I don't know. I know he had to go by 1:30. So if we are still around, I think it might be just, and Stephanie, you're the media expert, no expert. But if each one of us sort of maybe say, I don't know, what's something that happened, something that we think it's a significant progress in TAPS, and maybe something that we call for action or something that we, you know, give a message there. Would that be, do you think that would be nice? I mean, I don't know, my observation in these things tend to be nice for putting it on social media tomorrow.
That works pretty well because I've got a few, I've literally am still loading content as we speak. So we have a whole week of this going on. So it's, yeah, but like if you really want to, we can record something, you can say something, and then absolutely something that's significant is fine.
Okay.
Then we can
What
make
do you
it
think,
edit.
Gina? I know, I mean, Gina, I know it's early, darling, in the morning, and I feel so guilty about it, but I think you seem to be an early morning like me. You're early, but I mean, poor, you look beautiful, and you're like lovely makeup, beautiful, everything, compared to Ahmed. Usually he's a bit tired in the morning. It's too early in the morning for him. So yeah, I mean, I don't know. What do you think?
Yeah, go for it. I think say something profound.
I think we're still actually, can I say something?
There's no pressure, right?
No pressure.
Yeah. But can I say something? We're still actually on the webinar, by the way.
Yeah.
So we still have so I think why don't I'll send another link and then maybe you can connect and just
that's
okay.
yeah, that's fine.
Okay. But
That
thank you
sounds
so
good.
much, and I'll see you.